Okay, good evening, everybody. My name's Tim Bates. I'm one of the GPs here at Fort House Surgery.
My name's Ruth. I'm the lead women's health nurse. Nice to meet you all.
I hope then that we're going to be joined by a few people as we go on. But what we're going to do today is we're going to talk to you about women's health in particular. We're going to split the session into two. Ruth is going to take you through some of the new developments in women's health at the surgery here, and then take some questions and answers. And after that, then Harriet will join me and we'll go through some questions and answers that you might have about the general day-to-day running here at Fort House Surgery. Just a couple of housekeeping rules, please, if that's okay. We won't be addressing individual medical questions today. If you do have a medical need that you were thinking about addressing today or might come out of today's conversation, then please go through our website, Fort House Surgery, and we'll be happy to answer that there. But we're going to try and keep individual medical needs out of this conversation. Please obviously pop your comments into the chat function, and obviously we'd love them to be polite and constructive, and we'll try and tackle any questions that you have that come up. I've got two moderators online who will be trying to answer questions for us at the same time. We will keep the questions anonymous just in case there is a risk we're straying into any personal medical territory. It would be great. We'll try and keep all the questions anonymous. And whilst we're presenting, I don't think we'll be able to see the comments function, so we'll pick up the questions at the end, but Harriet and Mia are online to guide us there. So there's going to be a hard stop if we do get up to 7 o'clock, because that's just the way the IT, I believe, is programmed, and so we will be wrapping this up just a little in advance of 7 o'clock. So thank you for joining, and obviously we'll share the recording at a later stage. Ruth is going to talk you through our women's health services, so I'll let you introduce yourself.
Okay, so hello everybody, bear with me, I'm just going to bring up my little slides. So firstly, thank you for joining us. It's really lovely to meet you all via the web. I hope you find this platform useful. We are hoping that this webinar raises women's health services that we offer at Fort House, and also gains crucial input from yourselves on how we can improve the future of our women's health services within our team. We hope to answer any general women's health questions that you may have. If, however, you have any personal health questions, as Tim said, please just reach a clinical request form on our website, drop your request down, and we'll reach out to you and offer you a telephone consultation or face-to-face. Dr. Bates will be sitting next to me, so if you have any questions in general about Fort House, he'll be able to answer those in the second half of this webinar. So what to expect from today's webinar? So hopefully you will just get a brief overview of the services that we offer for women's health at Fort House, our team, what it's built up with, and our vision for women's health running into the future at Fort House. And hopefully at the end of this webinar also get some input from yourselves on suggestions on what you expect for women's health services at Fort House.
There you go.
This one?
Yeah.
Okay, so firstly, who am I? So I am Ruth. I'm the lead women's health nurse for Fort House. I've been working in women's health for the last 16 years. My background is I'm a nurse and a midwife, and I've worked in early pregnancy, emergency gynaecology, maternity, fertility, urogynecology, contraception services, sexual health, and accident and emergency. So I've had a variety of fields of experience in women's health, and I'm very passionate about it. Our wonderful women's health team here, we've got Dr. Hollowell, Dr. Teague, Mandy Wilson and myself, and we all work together, and Tim is our advocate for women's health, so he's our champion on progressing our services here, so we're very grateful for his support. As a team, we are extremely passionate about women's health, and we really hope that we can progress our services here and hopefully offer extended services for women's health, and that might be removing polyps, scanning, offering female physiotherapists. So, you know, fingers crossed, the future's looking bright for women's health here. Personal bits about myself. I have 2 children. I've got a 9-year-old daughter called Sienna, and I've got a 7-year-old boy called Josh, and I've also got my hubby who works in the medical field as well. I love gardening, socialising, travelling, and shopping. So that's a bit about me.
Oh, sorry. We're not doing very well, are we?
So I did some slides just to help encompass what we offer at Fort House in Women's Health Services. I wanted to do slides just to make sure that I don't miss anything, because usually I don't like talking to a full room of people, so please bear with me. So just a brief overview of all of our services, our vision, and then Tim's going to take over from there. So what is our vision at Fort House? So we spent quite a lot of time looking into the needs of patients at Fort House. And a reoccurring theme was identified through surveys and audits done by the team, and that reoccurring theme was women's health. So using this data, we were able to incorporate it and build and expand a women's health team. Our vision is to offer a high-functioning women's health service that can offer gynaecology appointments 5 days a week, face-to-face or over the phone. The ability to offer extended women's health services, fitting coils, contraceptive implants, pelvic health assessments, vaginal pessary fittings, and menopause treatment. We also hold a strong vision in improving our female patients' overall health, and overall health encompassing mental health, self-care, nutrition, exercise, diabetes prevention, cardiac health, breast screening, cytology screening, and bone health. So I'm just now going to run into the gynaecology service we offer and just give you a brief overview of the services that we offer, and then if you require those services, we've highlighted them on our website and you can book in to see us. So can I press this?
Yeah, there you go, there we go, someone just highlighted it.
Oh, fine. Okay. So contraception services starting off. So we offer a comprehensive range of contraceptive methods supported by NHS, including long-acting reversible contraception methods. So that's the hormone coil, commonly known as the Mirena, the non-hormonal copper coil, and the hormonal implant. I run a dedicated contraceptive service every Friday, supported by a lovely HSA Jen, and we also are hoping for Dr. Hollowell to train up in her Mirena coil fitting soon too. If you are unsure of which contraceptive method you would like, please do not panic. We have lots of information on our website, all the different methods you could look to trial. And if you're still not sure, then please reach out on the website for a face-to-face or telephone consultation, and we can run through them with you and make sure that they are medically appropriate for you as well. Excellent. So a big love of mine, pelvic health. So pelvic health encompasses prolapses, bladder behaviour, vaginal pessaries, and sexual function. So female pelvic health plays an important role in women's mental, physical, sexual and social well-being. Pelvic health includes the bladder, bowel and reproductive system. Women can experience disruption to their pelvic health from bladder urgency, frequency, infections and leakage, vaginal prolapses and constipation, or diarrhea and pain. Factors like pregnancy, childbirth and aging can cause these symptoms. We believe that it is vital that pelvic health support is offered within our women's health service. If you believe you may be suffering from one of these symptoms, please reach out on the website and we will be able to support you and do a full assessment with you. You may feel that you can't approach us because you feel embarrassed that you're leaking urine, or maybe you have a prolapse, but I can assure you, I've been in this field for 16 years, as has the rest of the team, and our rooms are confidential. We ensure your dignity and we will make sure you do not feel embarrassed, but our end goal is to support you with your pelvic health. Help that we can do with prolapses is something called a vaginal pessary ring, pelvic floor retraining, bladder retraining, and we can also offer referrals to physiotherapists and urogynecologists if needed. Okay, periods, how can we help? So menstrual cycles can vary. The normal range of a woman's menstrual cycle is every 28 days. However, regular cycles that last longer or shorter than this are also seen as normal. However, if you're experiencing very heavy periods, painful periods, extended irregular periods, persistent bleeding and/or emotional and physical difficulties during your periods, please reach out to us because there are ways that we can support and manage you. And this can be via medication or non-medication, but it's really important you reach out to us and we give you that support. So vulval care, how can we help? So vulval care involves the assessment and diagnosis and management of a range of conditions affecting the vulva, including skin conditions. This can be cracking, splitting, dryness, ulcerations, infection, itching and pain during sexual intercourse. Our team are able to offer an assessment, so if you come to us and you have a vulval complaint, we can look at your vulva and see what potentially is causing this issue and treat it. And if we can't treat it, we have the tools and abilities to refer you onto a specialist team within secondary care to support you. So if you have any issues with your vulva, again, reach out on the website and we can support you. So long-term gynaecology, it's a bit of a mouthful, long-term gynae disorders, how can we help? So that can be endometriosis, polycystic ovary syndrome, also known as PCOS, fibroids, ovarian cysts, prolapses and urinary incontinence. They are long-term conditions that can be managed within the primary care sector, so within our GP practice. So if you have a diagnosis and you're unsure that your management is correct, or you feel like you haven't had a follow-up within secondary care, please reach out to us, and again, we can support and manage your symptoms. And if you haven't had a diagnosis but you think you may have something like endometriosis, again, please reach out to us. We can assess you and explore possible diagnosis and referral to the right secondary care team if it's needed. So fertility, how can we help? So we understand the world of fertility can be overwhelming, especially working in fertility myself. I understand the emotional, physical impacts of subfertility when you're trying to conceive and it's not working. If you are experiencing fertility issues and it's been 12 months or more and you have no medical history of concern, please reach out to us again on website and we can discuss with you potentially what can be going on and how we can help you. If you have a medical background that potentially is causing you to have subfertility issues, and that can be that you've had cancer treatment and you've had 6 months of trying, please reach out to us and again we can support you and get you the right treatment. So pregnancy and postnatal care, how can we help? So my background is that I'm a midwife as well as a nurse, and all of our team have had experience rotating in obstetrics. So if you have any minor ailments in pregnancy, so that may be urine infection, a rash, please reach out to us, we can support you. However, if it's a serious ailment, so if you're experiencing dizziness, blurred vision, severe headaches, then you must seek medical attention. So heavy bleeding, your waters have broken, you feel that your baby's not moving as much as they normally are, then then you must seek urgent medical attention within secondary care. But minor ailments, please reach out and we can support you. Postnatally, if you have any concerns around your vulva, vagina, irregular vaginal bleeding, urinary leakage again, C-section scar concerns, breast concerns, please reach out to us, we can support you. So breast care, how can we help? So all women aged 50 up to their 71st birthday are invited for breast screening every 3 years. First invitations are sent between your 50th and 53rd birthday. However, if you are not in that age bracket and you experience abnormal symptoms within your breasts, and that being breast pain, red, hot or swelling around the nipple or the breast or under the armpit, there's a hard lump that does not move around, you get nipple discharge, sometimes streaking of blood from the nipples, if you notice that your breast has changed shape, if you notice there's puckering on the breast or there's orange pill appearance on the breast, or there's persistent itching of a nipple, please reach out to us. We can do a physical assessment and we can refer you early for a scan. You just need to book an appointment with us. So sexual health. So generally, rule of thumb, sexual health should be treated within a sexual health clinic. However, we know there's difficulties getting to clinics within this borough, so we can offer the basics of sexual health screening. So if you have abnormal vaginal discharge, itching, ulceration, an abnormal lump or bump come up on your vagina, abnormal vaginal bleeding, pain during sexual intercourse, Please do not worry. Book in to see us. We can assess what's going on. We can do routine sexually transmitted infection screening. And we can also do routine bloods to look at sexually transmitted diseases, and we can treat. But we will always recommend having a full service within a local sexual health clinic if needed. So again, just reach out and we can treat you. So Menopause, it has a wonderful new platform, and we are just so grateful that it's been brought to the attention of everybody. But I would just like to cover it again. So Menopause, how can we help? So menopause is when your periods stop due to lower hormone levels, and it usually affects women between the ages of 45 and 55, but it can happen earlier. Menopause can happen naturally or for reasons such as surgery to remove the ovaries, cancer treatment like chemotherapy, or a genetic reason. Sometimes the reason is unknown. Perimenopause is when you have symptoms of menopause, but your periods have not stopped. Perimenopause ends and you reach menopause when you have not had a period for 12 months. Menopause and perimenopause can cause symptoms like anxiety, mood swings, brain fog, hot flushes, and irregular periods. These symptoms can start before your periods stop and carry on afterwards. Menopause and perimenopause symptoms can have a big impact on your life, including relationships and work. We can help by exploring your current symptoms, periods, and lifestyle, and discuss both lifestyle changes, cognitive behaviour therapy, and the possibility of non-hormonal and hormonal medication. On our website, we've shared multiple links, so please go and have a look. There's the Women's Health tab. You can pop on there, and then once you've clicked on the Women's Health tab, you'll see that all of our subheadings of all the different areas that we cover and we can support you with, and you have evidence-based, reliable links to have a look at. Okay, so mental health, how can we help? So we know that with women's health issues, unfortunately, if they're not managed correctly, that will have a spiral effect on a woman's mental health. And so we know that it's vital that we support you with your women's health complaint, and then hopefully empower you for your mental health to be in a positive frame of mind. But we know that's not always the case, so we are here to help. So if you find that you are low in mood, you're unable to control your mental health, and it's affecting your workplace, it's affecting your home life, please reach out to us. We can explore what's the potential to why your mental health is low in mood. And it could be that you're on the wrong type of contraception, it could be a hormonal imbalance, it could be perimenopause. So it's really important you reach out on the website and we give you that support you need and hopefully get you on a better track. So leading on from mental health, we know that self-care is so important. So what we're trying to do is incorporate in our women's health service that we ensure that you are looking after yourself. We will of course encourage exercise, nutrition, mindfulness, but we will also be looking at your health as such. So looking to make sure you've had your cytology screening, you've had your recent health checkup, which looks at cholesterol, diabetes, risk of cardiac disease. We will explore what exercise you're actually doing, and what diet you're eating, how much alcohol intake you're having, are you smoking, and if you want to give up, can we help you to do that? But self-care is so important for a woman to be able to thrive and be happy within the home life, the work life, being a mother, and being a partner. It's really important. So self-neglect is one of our key targets for 2025 into 2026, and Dr. Bates will be covering self-care when he takes over as well. So unfortunately you can't see this slide, but I managed to do an example of our website. So initially where you go, and then clicking on women's health, and that leading on to our subheadings, which I was telling you about earlier, about all our different services and reliable evidence-based links to click onto to get further information. That we've had an overview in this webinar today. Alongside on the website, there's our wellbeing wall, which is wonderful. It covers lots of different organisations that are supporting women within Elmbridge. That's running groups, that's counselling services, and anything that's up and coming within Elmbridge that's going to help women to be happy. So I'm going to lead over to Dr. Bates now, and he's going to talk further about our vision.
Yeah, and look, I'm terribly sorry about the failure of our IT systems, because Ruth's put in a huge amount of work and a great presentation. I'm just sorry we can't show it to you. And we've got a little kind of picture around our vision for women's health here at Fort House Surgery, and I think it's one that we'll maybe try and share after the event. In fact, I reckon I might even be able to cut and paste it and put it into the comment section here. We'll see if that works. Oh, of course it doesn't. We are really interested in helping all of our patients live healthy lives, and we're interested in illness prevention. I've heard the National Health Service described as the National Ill Health Service, that we spend £120 billion a year on ill health, and it's a really good challenge to say, well, what can we do as medics here at the surgery and as members of your community to help people live healthier lives? And that's where the Wellbeing Wall is coming in, and Harriet's just put the link to our women's health section on our new website. I think it's our 4th website now in the last 2 years, because we're working hard trying to improve it. And you'll be able to find links and advice about a lot of common conditions, but also around opportunities for fitness and activity and healthy living and self-care. Obviously, once you contact us at the surgery, you can meet any one of our clinicians here, any one of our paramedics, nurses, pharmacists, and our GPs who work here. So we're working hard behind the scenes to try and make sure that that first contact we try to get right. We have a fixed twice yearly training session now. Mandy took her first one in March, well, this month, sorry, just gone, where she looked at menopause and was trying to give us updates on menopause and perimenopause. So the idea is that we will try to get questions answered and give as much information as possible at that first point of contact. Dr. Teague is working on a directory of resources for us to then be able to give further information off the back of that consultation. And then obviously we've got the women's health team here, our 4 colleagues, 2 nurses, 2 doctors, who can then sort of take on any more specialist community gynaecology or women's health issues that Ruth's just outlined. I will try and share that graphic because we think it's a nice one, and we think it tries to explain our vision here. Obviously, anyone who needs further referrals to secondary care, we can access that. We try to do as much in the community for you as we can. And then obviously we're back to the beginning, which again is living healthy lives and preventing further ill health. I was going to touch on the why. I mean, I think it's always kind of important as to why we're here and why we're having this conversation. We've spent quite a lot of time over the last couple of years looking at demand, where health needs are, where our unmet needs are, and we've audited quite a large group of people. When we looked within the areas of health needs, we found that women's health was not simply gynecology or obstetrics. Oh, and by the way, thank you so much to the 159 patients who took part in our survey, because we ran the audits, we identified a problem, we discussed it at a clinical meeting and thought, well, what can we be doing better here? And then Dr. T put together a little survey for us. So to have such a high number of responses from you all was brilliant, and it's really informed the service development from here on. But we found within that people had complex needs, and they didn't just fit a single specialty area like obstetrics and gynecology. Almost half of our patients expected to be requiring help with their mental health over the next 5 years. We found that quite a few people were carers, and we should be thinking about more holistic needs of our carer population. We found that women in the age of 40 to 60, almost half had seen a gynecologist in the previous 3 years. Almost half had been treated for menopause or perimenopause. And then we found a surprisingly high number of other conditions like musculoskeletal pain, like metabolic conditions such as diabetes and pre-diabetes. And so we really realized that we shouldn't just be focusing on simple procedures here, but actually a more holistic approach to the health of our female patients. The survey was really quite instrumental, wasn't it, in how we could then take that information, align it to our audits, and then build the team and build our vision, which hopefully we'll be able to share with you. Our last slide really was an appeal, wasn't it, Ruth?
Yes, please. We would like to know how you can help us. So can you please reach out to us, whether it's email or on the chat here on our webinar, just to tell us what you are expecting for Women's Health Services at Fort House. What would you like? How can we improve? We will not take offence. We appreciate your feedback, and we will take it positively, and we will work on it. But we want to make sure we're delivering the best women's health services possible at Fort House for you.
Okay. We've got one question, we'll come to that, and we've had a couple of questions submitted in advance, which is more just on general practice data, so we'll bring so we'll bring Harriet in a second. Please pop your comments and questions in the chat function. Let me pick up the question that we've got here. Why does breast screening stop at the age of 71? Do you want to take that?
Yeah, sure. So breast screening tends to stop at the age of 71 because your risk of breast cancer drops significantly. However, the NHS programme still allows women above the age of 71 to still screen. So if you wish to have a screen after the age of 71, even if you're low risk and you're no longer invited, they still allow for you to phone. There's somewhere called the Jarvis Centre, which is where most of our women go in Elmbridge. So you can phone directly and they will book you in.
Fantastic. And thank you for the nice comments there as well. I'm just still trying to fight this IT and see if I can do something to copy in. Have we got another question?
No, I did have a question shown by the admin team about HRT and breastfeeding. So if you feel that you need to start HRT whilst you are breastfeeding, that will need to be specialist advice sought within secondary care. So please reach out on our website, ask for a telephone call or face-to-face, and we can discuss your potential symptoms and support you.
Okay. If there's a strong family history of breast cancer, are you able to access screening before the age of 50?
There is a possibility. Reach out, book an appointment, and we'll talk about it.
Yeah, 100%.
Yeah.
And we certainly have a cohort of women in their 40s and 50s with very strong family histories. Firstly, we can make referrals to the breast team looking at whether genetic screening might be an option. That's supported by the genetic counselling service up at St George's. So that would be looking particularly for the BRCA1 and 2 genes, is that right? Mm-hmm. And secondly, for high risk ladies, there is an option to have annual mammograms between 40 and 50 as well. We've got a question now about HRT. When do you take the progesterone? I think this is a question about when you take progesterone. Do you take it in days 15 to 26, first 2 weeks of the month, in the middle of the cycle? Ruth, do you want to talk about different types of HRT and see if we can sort this one?
So HRT is a minefield. It depends on which progesterone, but most progesterones tend to be between day 15 and 26, or some may say day 14 to day 28. But if you are uncertain and you're one of our patients, then please reach out. We can go through your program with you. It's no problem. And if you're not a patient of ours, then reach out to your own GP and they'll be able to go through it with you. Make sure you're taking it correctly because we need to protect that lining.
Okay, and I think it's really important to talk about why we use progesterone in women who are taking estrogen and who still have a womb.
Yes. So the reason why we put you on progesterone is to protect the lining of your womb. If you were to take estrogen without progesterone, the lining of your womb would thicken and you would be at increased risk of endometrial cancer, which we do not want. So it's really important that we keep you on progesterone. There are 2 ways of taking it. If you've had no periods for 12 months or more, then we'd expect you to be taking progesterone every day. If you are still having periods, then it would be for 2 weeks of your HRT cycle.
And I was just looking at some of the questions, so forgive me if I tuned out, but there is an option to go from cyclical to continuous once you've been on it for long enough, is that right? Yes. Or there's an average age at which you've got the option to go straight on to continuous?
Yeah, so each individual is different, but yes, depending on your age and where your periods are sitting, your bleeds, then we may be able to put you over to continuous.
Okay, all right, thank you. I'm really loving these questions coming in, so it's wonderful, thank you. The question about the booking system I will tackle with Harriet in the second half, and I think that we'll be able to explain the system we have now, why it's working, and and so I'll pick that one up later. So we've got a question: is it possible to have full blood work check done even if we've got no particular symptoms to see things where things are hormonally? And I think that we do get quite a few requests for hormones like FSH and LH, particularly from younger women who might be premenopausal, and I think we've got some information about how effective that is.
Yes, so some women may want a hormone profile because they're trying to conceive. Others may want it because they think they may be perimenopausal or postmenopausal. We know evidence-based that hormone profiles alone are not reliable. So it's really important that we see you and go through a full assessment with you of your symptoms and what you're seeking. And alongside the hormone profile, we can make a decision on our diagnosis and plan for you, whether that's trying to conceive or looking around perimenopause or postmenopause.
They're flying in, Ruth. This is great. Okay. Any update on when Estradot will be available again? I appreciate that question because the drug shortages, we are tearing our hair out. I can't say why it happened, but we seem to have lost our ability to trade and access goods and services from our nearest neighbours. And at the moment, we've got about 200 different drug shortages. I mean, today I was changing tablets for someone who we changed tablets 2 weeks ago because their original tablets weren't there. So we had to come up with an alternative, and now the original tablets are back in, and it's creating a huge amount of work for us. I'm afraid the answer is we are entirely subject to the market forces around the wholesale movement of goods and how they then come into the retailers that you're interacting with locally. All we can say is we will work with you, and we've got a pharmacist on our team, Bao, who can help us manage drug shortages as well. These things come and go, and it is a little bit like whack-a-mole, trying to find the right prescription at the right time. Hopefully the supply issues are temporary rather than permanent. So we don't know, but supply issues are a common issue, and Bao, our pharmacist here, can help. We will always be able to find you some form of effective estrogen delivery because we don't want anyone to be experiencing withdrawal symptoms because of a supply issue. Let's work through. There's another question about our systems and medication reviews, which I'll pick up a bit later. Dexa scanning. And also quite rightly flagging about strength training to try and keep bone health, bone density going. So Dexas, do you want me to pick this up?
I think you can pick that one up. Yeah.
Okay, I mean, there's no national screening agenda here. There's lots of guidelines and recommendations, both within the world of women's health and throughout other medical problems or other medical specialties that could be associated with a low bone mineral density. For instance, rheumatology drugs, other disorders like thyroid disorders, chronic liver failure, and so on. In general, I would be thinking about my family history and my relatives and whether they have a history of fractures. If you're interested, you can do your own calculation online. There's a tool called FRAX, and there's an FRAX, there's another one called QRisk, and you can generally put a lot of the data in there yourselves because it relates to your personal medical history and your family history. If you are interested, then please speak to us and we can talk you through your risk factors. We can generally run a fracture risk here, and then on the basis of the predictive tools that we've got, we can book bone mineral density scans, or to be honest, if you just insist on one, we'll happily do it because it's good to know where your baseline is. I think we all know that postmenopausally bone mineral loss accelerates. We're all losing our bone strength from the age of 21, but it is accelerated post-menopausally. So I think anyone who is post-menopausal with a family history and any individual risk factors, please talk to us and we'll happily arrange bone scanning. And I love the fact that strength training, any fitness training, anything that keeps a little physical stress going through your bones is great to stimulate your bone matrix. You've got cells in your bone that break bone down called osteoclasts. You've got cells that make bone called osteoblasts. And this kind of impact type exercises, whether it's running or any HIIT or strength training, is great to stimulate your bone matrix and lay down new bone and slow the bone loss. Also think about calcium in your diet, lots of green leafy vegetables as well as your dairy products. Most of us, if we're eating our 5 a day, have got at least 1.5 grams of calcium in our diet, so that's great. And vitamin D is important. You can supplement over the counter, usually 800 units, international units a day of vitamin D. And you know, there are certain foodstuffs, particularly fish oils, that are very rich in vitamin D as well. So again, we're happy to talk you through that. This is a lovely example around women's health is not gynaecology. Women's health is a holistic, broad subject, and we're really keen to embrace that. Wonderful. We know Ruth's amazing. That's wonderful. Okay, coil fitted, no period, HRT. Do you want to say something about the Mirena coil, normal impact on periods? And then I'm assuming this is a question about fitting a coil
so she's already got a coil fitted.
Pre-menopause. Yeah.
So depending on your HRT regime and what your periods were like pre-coil fitting and how long the coil's been fitted for, the Mirena coil, so it's a hormonal coil, it's progesterone. We expect by 6 months of fitting that around 90 to 100% of your bleeding stops completely. And it's unlikely that bleeding will come back until around 5 years. If it's for HRT, you may start to experience some bleeding. And if it's for contraceptive purposes, you may not experience bleeding for up to 8 years. It's licensed for 8 years for contraceptive purposes. So depending on what age you were when you had the Mirena coil fitted, again, there may be that you have gone into the menopause, and we would need to explore that with you, and we can do blood tests and review that with you. Okay,
and again, if we need to go into medical issues a bit more deeply, please contact us through the surgery, and we can help. Right, I think that's an answer, so we'll skip that one. Ruth, we will share Ruth's slides, won't we? Because you work so hard, and I really want to share our vision for women's health and that and how we're adjusting our operation behind the scenes here. Okay. Oh, we've come to the end of the questions. Are there any further questions that you would like to pose to Ruth before she disappears? I think there's one just popping in, and then Harriet's going to come in and join me, and we'll get on to general operational stuff. Can we, I assume that means any female patient who's interested, be sterilised instead of taking hormones for the next 30 years?
Sorry, what was that?
It's a question about sterilisation instead of hormones. And I think maybe we need to talk about hormonal gynaecology and functional anatomical gynaecology.
Yeah, I think this is quite a complex question. This would need to be explored. Why would be your reason for this? So I think it would need to be more of a face-to-face, because it sounds like we'd need to go through all of your aspects of health and lifestyle and why you'd want to opt for sterilisation rather than hormones.
But sterilisation is a contraceptive. It stops you getting pregnant. It won't affect any of your hormonal cycles. So it will just stop the ability for an egg to travel from the, and Ruth's going to correct me if I'm wrong, from the ovary through the fallopian tube to the womb. So an egg can't meet sperm and fertilisation cannot happen. But all of the hormonal cycles that still run a normal system will still be running. So sterilisation won't change any of your hormonal profile at all, or bleeding profile at all.
No, it won't change that, but I think what she's saying, Tim, is she's looking at normal babies, so from a contraceptive purpose. Yes, okay. So we would need to explore that with you and discuss the risks and benefits of sterilisation and look at referral for you.
Okay, it's still an option, isn't it? Okay, yeah. So this is a pre-menopause question, not a menopause question. A baby question rather than anything else. Good. Okay. Right. Thank you very much, Ruth. It's been brilliant. Thank you so much for joining us, and we'll bring in Harriet, and then I'll take the first question that we've got here, which I think Harriet's answered about the booking system. Do we ever think we'll go back? Just to recap, I've been here 20 years, and in 20 years we changed our systems in 2008, 2013, 2020, 2022, 2023, and there's a little bit going on behind the scenes, 24, 25. Our motto here is traditional general practice in the 21st century. We're really interested in preserving the product of traditional general practice. That's really important to us. But there are two realities. Number one, we live in a digital age. And number two, that the demands on general practice have changed at the same time that the resource envelope has significantly shrunk in terms of people and also cash, though I know we might have a question about some of the funding that the Health Secretary has talked about in the last few weeks. So the reality is that we've had to adapt our model really quickly in the last few years, haven't we, to try and protect core functioning and the core values of the surgery, but in a digital age with escalating demand. So the answer is no, I don't think so. But what the total triage model allows us to do, so the forms that come to us, either you submit them directly or you speak to our receptionist, and our receptionist will put the form in for you. It allows us to make sure that we can, number one, address any urgent issues. And we talked about heart attacks and allergic reactions last time and so on, that we could pick up straight away and deal with immediately. But also it allows us to move, well, maybe we can deal with your question there and then. It allows us to book an appointment with the right clinician for you who's got the right skills, and it also allows us to do a certain amount of work before an appointment. So for instance, if someone who is 75 and is experiencing significant knee pain, which is limiting, you're going to need an x-ray. We can book an x-ray and then see you with the results. And that then allows us to generate efficiencies with the resource limitations that we've got. So that example would be, traditionally 20 years ago, you'd see me with a hurty knee, I'd x-ray you, you come back and see me. This time we can actually x-ray you and then you come and see me, and we'd be able to sort out your problem there, and then that would save us an appointment. And what we've shown here is that we have been able to increase our activity. I've quoted data before from 2013 to 2022, where we are on average seeing every person 5.2 times a year, and that's an increase from 3.5 times a year in 2013. So we've increased our appointments per person 49%, but we've not had a 49% increase in resourcing. Because we've got more efficient, and because the challenges remain very serious for us and very severe, the reality is that we need to stick to the system, but try and protect the core values of general practice within this digital age. So we won't be changing, I don't think. I suppose one question is, well, what are the core values of general practice? And the work that I've been doing around unmet need and how we can improve our access to services has really looked at how can we improve continuity as much as maintain access. And we know, I think I've quoted this before, that continuity makes a significant difference to your outcomes and your well-being. If you know your clinician and you've known your clinician for more than 15 years, your risk of dying from all causes drops by 25 to 30%. This is data from Europe. It was heard at the Health Select Committee. Not only that, but patients are more likely to follow any advice we give, more likely to make lifestyle changes around smoking or alcohol or diet or exercise, less likely to go to A&E, less likely to be referred into hospital. So we have been trying behind the triage wall, behind the website, to improve continuity of care. And so I think if we can maintain that and protect that, then you should still be able to experience some of the positives of the traditional system, but we're still able to thrive in the environment in which we have found to be very challenging. But I'd like to think that we've managed to try and protect you from those challenges as much as we can. Okay, any other questions, Harriet?
Well, let's go back to the one that was asked earlier.
Medical reviews. I've written that down. So how often do we do a medical review? Annually. I think it depends very much on the condition. It depends very much on the medications as well. We are looking behind the scenes at introducing a virtual medical review model. I think that would make perfect sense for someone who needs some nasal sprays or some antihistamines on a seasonal basis. It makes no sense for someone who has, for instance, Parkinson's disease, heart disease, chronic obstructive pulmonary disease, diabetes. A lot of those reviews need to be undertaken face to face. But looking at some of the best practices around Surrey, we've been told that up to 70% of medical reviews could be undertaken remotely, and that would then free up time so that we can dedicate more clinical time face to face for the patients who need it. So annually, it might not have to be in person if it's simple. It should be in person for more complex areas. And some drug monitoring needs to occur every 2 months, 3 months, 4 months. So we try and run that behind the scenes. We have tried to improve our back office function, haven't we? So we've got more administrative support, and our partners here, Louise Carvalho and Sitso Manqua, are leading very much on prescribing and chronic disease management, and making sure that we are trying to get the recalls right. And one of the other things we're trying to do is not send out 4 letters for 4 appointments for one patient with 4 different conditions, and try and coordinate it as well. I doubt we're perfect on it, so if you do see anything that we're doing that doesn't make sense, please don't hesitate to get in touch. There is, if you go to collect your medication, answering this question, do we request a review or do you call us in? The answer is both, and 2 minds are better than 1 here, because we are genuinely terrified about people slipping through the net, but it happens, especially when you're running such a large operation. If you collect your prescription, you're given a little printout. It's known as the right-hand side. You used to get it from us, now you can get it from your pharmacist. And at the bottom, it should say medication review due. You've also got your pharmacists who are looking at your last medication reviews as well. And they're another layer of protection, making sure that the drugs issued are appropriate, that they're minimizing risk of prescription errors. They'll be flagging when things might interact, and they'll also be flagging when your medication reviews are done as well. We have, as part of our contract with the government, something called the Quality and Outcomes Framework, which is known as QOF shorthand, and that is for our common long-term diseases such as diabetes, hypertension, asthma, COPD. So we have performance targets that we have to meet. The end of the QOF year is this end of this month. Historically, March has been an unpleasantly busy month because we've got a mix of seasonal ill health, day-to-day ill health, and then trying to rush through all the QOF checks. But Charlotte Budkovich, who is our new partner here, I think we've released a newsletter today detailing some of the partnership changes. So Charlotte, who's our nurse practitioner, is now going to be one of our new partners, is leading and has done some brilliant work on our long-term disease management, and so we're managing to spread some of those reviews out through the year, and we have a working theory that maybe we'll try and move towards a birthday model, so that we can look at everybody who was born in June and then try and get their checks done in and around June, and use that as a trigger so we can begin to even those checks out through the course of the year. That's a big operation. I think we've got something like 400, 500 asthmatics, and we're going to have easily 1,000, 2,000 people with long-term conditions to run annual checks on. So we're going to try and get a bit more efficient about this behind the scenes.
Right, so the next questions come in. When you get a response from a GP after filling an online form, why don't you always get the ability to reply? I think we did deal with this one in the last website, but we'll almost go through it again. So if a GP asks for some further information, they will put a link where you can actually respond. It could be photos they want or additional information they want. The problem with putting a reply link in everyone is these can come out of hours. You could do it later in the evening. That could then come back into the duty team, but it might not be the same doctor that you spoke to originally. That request will still be open, and we run the risk of not completing or finishing what you actually asked for in the first place. So I do appreciate it can be difficult, but we have to be able to manage those requests when they come in and ensure we have completed them and we have given you the appointment if you need it. As I say, when a clinician wants some further information, they will normally put a link on the message so that you are able to come back with it. But I do appreciate that isn't always the time, but it is a safety element. We need to make sure that those consults are sorted and we get you the right treatment and the right appointment as soon as you submit it.
Thank you for the lovely comments as well. It's really,
yes,
we really appreciate it. And I know a lot of our team will be watching. I know a lot of our relatives are watching. Hello, Mum. And I think that positive feedback like this it ripples out through the team, and it's so well received, and it's nice sometimes for our families to know what we get up to as well, isn't it? So that helps. Unless, please, if there are any further questions, we've got 6 minutes left, I should say. I've got a couple of questions that have been emailed in. Why do we need to increase our patient list size when it's getting harder to book an appointment with a clinician of choice? I can understand the sentiment here. I think it's been difficult. It's been difficult since we've moved. I've heard people saying that we're not the same since we moved, and unfortunately we moved during this absolute storm post-COVID, and make of the management of primary care what you will over the last 5 years, but I can't speak particularly highly of it under the previous administration. So yes, there have been challenges. There have been challenges around continuity. Last year, we've highlighted was particularly challenging with 2 of our regular doctors on maternity leave. One of our doctors developing a very serious illness. I'm thrilled that she's coming back in, aiming back towards full-time work, a really valuable member of our team. So providing continuity when people are off on legitimate grounds has been challenging. Interestingly, when we look at our continuity rating for last year, our average continuity rating was around 6 doctors per person. That's dropped to about 5.6. Maybe there's some complicated sort of statistics to explain behind that, but I'm saying that our stats show a slight improvement, and I think that we're confident that 2025 will bring a better improvement. Clinician of choice, we always offer access over continuity, but we're aiming for continuity where possible. Yes, there have been pressures on appointments, but there are also business pressures as well. Essentially, the funding of any practice, the money follows the patients. And we have very little option to cover any of our rising costs or overheads, or to try and finance any of the extra projects or extra work we're doing here to try and innovate without there being an allocated funding stream. So the reality is that we've learned over 20 years physically to put a pint into a half-pint pot, if you remember Fort House surgery and how tiny that was, but we've also been doing it organisationally here as well. And so with the efficiencies that we've got, we're confident that we can manage your health needs efficiently, and we're confident that we can aim for that continuity of care. I know there's a lot of improvement that we can still offer here, and we can offer that access as well. But without being able to grow your list size, you can't grow your revenues, and without growing your revenues, it's very difficult then to provide the service, because I mean, I don't know any major corporation that has a limit on who they can actually, on their customer base. And if we don't have those revenues flowing, we're not able to pay for existing services, and we are desperately trying to avoid having to shrink our operation here to match the revenues. And we won't be able to innovate beyond the current existing service. I don't think. Well, firstly, I'm not aware of any other practice that operates under a list restriction at all. So there's no other model for it that I'm aware of anywhere else in the country. So we are rather unique in that way, and that's why we are going to be applying to remove the cap on the list. But secondly, access and continuity are important to us. If people are not getting that, please tell us. And we are continually monitoring our access to appointments. And we're continually trying to make sure we've got the right staffing, but also trying to learn where we can do things more efficiently, but maintain the standards that are important to us to really try and protect those traditional general practice values. So business reasons, but we want to protect core values. And if we're not, we expect you to be telling us. In all honesty, that's why we're in front of a camera right now. I've got 2 minutes. Oh, last one.
No, can we have that one next, please?
Oh yeah, diabetes specialist. Oh yes, so Charlotte Budkovich, our nurse specialist and new partner, will be our diabetes lead. She's supported by Jo Dobson, who is our practice nurse, and so we do not anticipate any interruption to our diabetic care, and as ever, we will continue trying to improve it. How are we spending the extra money that the government are giving us? You will have seen the headlines around 900 odd million pounds worth of funding, and some of the headlines trying to avoid the 8 a.m. rush, trying to avoid the rush for appointments, and trying to improve access and continuity. Long story short, I think that everything that I've seen so far, we're already providing, and we took steps with moving to this total triage model to move away from the 8 a.m. rush. By moving as much online as we could, it has freed up our phones, and it's allowed us not just the efficiencies with managing the requests and cases, but actually the back office function as well. So I think that actually we're doing a large amount of what the government are aspiring to do. And just to recap, the DASI model is about moving care out of hospitals into community, moving analog into digital, and focusing on prevention. And that, I think, will leave it at 1859 before this shuts off, that the aspirations of the government have been the core functioning of this surgery for the last 5 years. Thank you to everyone.
Thank you very much
for joining us.
Do keep continuing to put comments in. I'm very happy to continue answering those as we go through. We'd love to have your ideas for the next webinar. We'd love to know what's important to you or what information you want from us. We're very happy to do these again.
Wonderful.
Thank you very much.
All right. Have a good evening.